Welcome to The Explainer. Today, we're jumping right into a critically important clinical pathway, the Cardiac Nursing Study Guide. Now, for this explainer, we're ditching the distracting, useless pictures. Seriously, we are focusing purely on the text. We're going to rely on high-retention words, acronyms, and hard data to systematically lock every single detail of cardiac care right into your memory. Whether you're prepping for a massive exam or literally stepping onto the clinical floor, the information we're going over today is absolutely designed to help you save lives. Let's get into it. Here's our agenda to conquer this pathway. 1. Mechanics and EKG rhythms. 2. Heart failure and disease. 3. Diagnostics and cardiac biomarkers. 4. Cardiac medications and bypass. And 5. Patient risk and quick numbers. Starting off with Section 1, Mechanics and EKG rhythms. We're looking at the electrical spark of the heart, how conduction actually works, and what it looks like on an EKG when things go haywire. Okay, let's trace the exact path of cardiac conduction. It all kicks off at step 1, the SA node. Think of this as the heart's natural spark plug, firing at a nice steady 60 to 100 beats per minute. From there, the signal travels to the AV node, which actually creates a tiny intentional delay, just so the atria can finish pumping. Then, step 3 is the bundle of His, basically the bridge down to the ventricles. At step 4, it splits into the left and right bundle branches, and finally, step 5, the Purkinje fibers, which trigger that main ventricular pump. To instantly lock this exact sequence into your brain, just remember the phrase, Sally always brings hot puppies. SA, AV, bundle of His, branches, Purkinje. You'll literally never forget it. Now let's contrast two massive cardiac emergencies strictly by their clinical definitions. First, we've got asystole. This word literally translates to a flat line. There is zero electrical activity happening. And because there's absolutely no spark to reset, your only moves here are CPR and epinephrine. You never defibrillate asystole, period. Now contrast that with VFib, or ventricular fibrillation. This is a totally chaotic rhythm with no effective pumping. But because the heart is, quote-unquote, still fighting, you've got to defibrillate immediately. The golden rule? Shock the wiggly line, but push meds for the flat line. Moving on to AFib, or atrial fibrillation. The key clinical definition you need to remember here is irregularly irregular. You won't see any clear P waves on the monitor. Instead of a strong, coordinated pump, the atria are just shivering like jello. And because the blood is just pooling and quivering up there, clots can form super easily. That's exactly why your main priorities are to closely monitor the patient and get them on anticoagulants to prevent a stroke. Moving right along to Section 2, heart failure and disease. Let's see what actually happens when the physical pump fails or the coronary pipes get blocked up. Check out this brilliant memory trick. We're using the literal letters of the conditions to map out the symptoms. Let's look at left-sided heart failure first. Left equals lungs. Blood backs up into the lungs, right? So your symptoms are going to be respiratory. A nasty cough, wheezing, orthopnea, which just means they can't lie flat to breathe, cyanosis, and blood-tinged sputum. Now flip over to right-sided heart failure. Right equals rest of body. The blood backs up peripherally, so you get symptoms like pitting edema in the legs, ascites in the belly, jugular vein distension, and even an enlarged spleen. Left is lungs, right is rest of body. Super simple, right? All right, let's define two major disease processes. First up is CAD, or coronary artery disease. Think of this as a pure plumbing problem. Plaques build up and narrow the coronary arteries, starving the actual heart muscle of blood. This directly causes angina, that classic chest pain, and can eventually lead to an MI, a heart attack. Next, we have endocarditis. Notice where this starts. It's often an oral infection that literally travels inside the heart, which can trigger severe sepsis. To diagnose it, you absolutely need both anaerobic and aerobic blood cultures, and you'll want to check the CPK-MB isoenzyme to measure the extent of the tissue damage in the heart. Section 3, Diagnostics and cardiac biomarkers. So we've talked about the problems. Now let's focus purely on the raw data and exams we use to diagnose them. Before we even think about drawing blood, we've got exams and clinical assessments to run through. Notice the clear distinction here. An angiogram is invasive. It uses dye and a catheter to get right in there and assess vessel damage. On the flip side, an echocardiogram is non-invasive, using sound waves to take a picture of the heart. And obviously, your EKG is there to detect arrhythmias. But I really want you to focus on the JDAD squared assessment acronym. J is for jugular vein distension. A is for apical rate. The second A is for angina. D is for diaphoresis, sweating. And the last D is for dyspnea, shortness of breath. Master that text, and your clinical assessment is totally locked in. Okay, this data is absolutely crucial, so let's break it down line by line. Troponin I, that is your gold standard. It's the most specific marker for a heart attack, and it actually stays elevated the longest, up to 10 days. Myoglobin, on the other hand, is the earliest to show up, rising just 2 hours post-MI. But heads up, it is not cardiac specific. Then there's CKMB, which peaks at 6 hours and confirms actual myocardial tissue damage. D-dimer's a big one. We use this to rule out clots, like a DVT or a PE. If that's elevated, your patient is clotting somewhere. BNP is your go-to marker for heart failure. It basically measures volume overload. And finally, for routine cholesterol screening, the golden rule is to keep that total under 200 milligrams per deciliter. To really anchor the timeline of those first 3 heart attack markers in your brain, just use the phrase, "my car travels." My is for myoglobin, the earliest riser. CAR is for CKMB, the middle marker peaking right at 6 hours. And travels is for troponin, the gold standard that travels the furthest, lasting up to 10 days. So next time you're staring at lab results, just think, "my car travels," and you'll nail the chronological sequence every single time. Moving on to Section 4. Cardiac medications and bypass. This is where we strictly look at how we pharmacologically and surgically fix these issues. Let's talk about the absolute gold standard for chest pain, nitroglycerin, or NTG. You have to know the life-saving 1-5-3 rule. It's the very first drug you grab for angina, but the protocol is super strict. You take 1 tablet, you wait exactly 5 minutes, you can repeat this up to 3 times. But here's the kicker. If there is absolutely no relief after that 3rd dose, you don't wait around. You call 911 immediately. Now, as amazing as nitroglycerin is, the side effects can be intense, and you need to know when they warrant a 911 call. You've got to watch out for extreme tachycardia, severe headaches, nausea, and massive hypotension. Because remember, NTG is aggressively dilating those blood vessels, which tanks blood pressure. Often, they'll see aspirin given alongside it. Aspirin's main job here is to decrease clotting, and you'll usually see patients put on a strict 81 milligram maintenance dose to protect their heart for the long haul. Next up is digoxin. This is a real heavy hitter, used for heart failure and AFib to slow down the heart rate while strengthening the actual pump. But pay attention to that capitalized warning. You absolutely must check the apical pulse for 1 full minute before administering it. If that heart rate is under 60 beats per minute, you hold the drug and call the provider. No exceptions. Also, watch out for toxicity signs. We're talking severe nausea, bradycardia, and a very weird specific visual change where the patient literally sees yellow-green halos around objects. Now, check out this critical clinical connection. Look at the warning for furosemide, better known as Lasix. This is a loop diuretic. And here's the thing, loop diuretics aggressively waste potassium. Why does that matter? Because low potassium, hypokalemia, drastically increases the risk of digoxin toxicity. It's a huge domino effect. So if your patient is taking both Lasix and digoxin, you've got to watch their potassium levels like a hawk. Sometimes meds just aren't enough, and we have to turn to surgery. Enter the CABG, or coronary artery bypass graft. This procedure literally bypasses blocked coronary arteries, usually by taking the saphenous vein from the patient's leg and grafting it in to restore blood flow. Post-op, your job is to hunt for infection using the TRIP acronym. T is for an increased temperature, R is for redness at the incision site, I is for purulent incision drainage, and P is for pain, usually accompanied by an elevated white blood cell count. Finally, Section 5, patient risk and quick numbers. Let's wrap this explainer out by focusing on what the patient can actually control, followed by a rapid-fire cheat sheet of numbers you absolutely need to memorize. This outlines a perfect dividing line between risk factors using 2 simple acronyms. First, the stuff you're stuck with, AGE. Age, genetics, and ethnicity or sex, completely unchangeable. But on the other hand, we have the modifiable factors, WEDS, weight, exercise, diet, and stress. This is exactly where the patient has to step up and take control, right alongside managing their cholesterol and actually taking their meds. Okay, let's kick off our rapid-fire numbers cheat sheet. When we're looking at total cholesterol screening, what's the magic goal? You want to keep it under 200 milligrams per deciliter. Simple as that. Let's keep the pace up. When you're monitoring a patient with heart failure, daily weight checks are literally everything. Why? Because a 2.2-pound weight gain on the scale is exactly equal to 1 liter of retained fluid sloshing around in their body. That is a huge deal. Let's quickly recall the max nitroglycerin protocol. 3 doses, spaced exactly 5 minutes apart. And to finish off our cheat sheet and lock this into your brain, hold digoxin if the heart rate drops under 60. The standard aspirin maintenance dose is 81 milligrams. And troponin, the ultimate gold standard lab marker, can stay elevated for up to 10 solid days. See? We stripped away all the visual clutter and focused purely on the text, the acronyms, and the raw data that actually matters on the clinical floor. By trusting these exact words and numbers, you've got a complete roadmap to understand conduction, spot a failing pump, and deliver the exact life-saving interventions needed. So my question for you is, are you ready to take these mnemonics out into the real world and use them to save a patient's life? Thank you so much for joining me on this deep dive. Keep reviewing this text, and you are going to absolutely crush cardiac nursing.